We are good to start, sir.
Good evening, friends. Welcome to this Tuesday evening programs from Yashoda Group of Hospitals from the Department of Critical Care Medicine and other specialties. It's another evening with a new topic that is a special and a common concerns for many of the intensivists when it comes to hematological emergencies. So today we have none other than Dr. Ganesh Jaishetwar sir, who is a senior consultant, a seasoned clinician, an academician, and has been a part of many academic programs and bone marrow transplant in this part of the world. Dr. Ganesh sir, it is an honor and pleasure to actually request you to be on board. It is our privilege to actually have you on board. Can you be on camera, sir, Dr. Ganesh?
Yes, sir. Thank you so much. Good evening, sir.
Yeah, good evening. So we will be today discussing about hematological emergencies in intensive care unit. They are a wide spectrum of disorders which we face across in the ICU, from a regular thrombocytopenia to a HOS, TTP to a inflammatory phenomenon to a hyperferritinemias and many more. So it has been a common practice for many of us that the hematologist on board sometimes give us those kind of add-on clues to us of a diagnosis and therapeutic options, and which makes our patients better and regain the recovery quicker. So it is over to you, Dr. Ganesh sir, for your presentation. Then we'll take questions from the other delegates and audience. Thank you.
Thank you, sir. So, good evening, everyone. I hope my slide deck is
Visible.
visible and I'm audible.
Yes.
Sorry for the little going through asthma exacerbation. So, at the outset, I would like to thank the critical care team of Yashoda Hospital, Hitec City, under the leadership of Dr. Venkat Kola, sir. And it is indeed an honor and privilege to present this topic, hematological emergencies in ICU. So again, thank you to each and every one of the eminent clinician present virtually for this weekly webinar run by the Yashoda Group of Hospitals Critical Care team. So again, my special greetings from Yashoda Hospital, Hitec City, and special thanks to Venkatramana Kola sir for this opportunity. So when Dr. Kola sir yesterday requested me to present this topic, this was my mindset, amidst the vast hematological spectrum presenting in ICU, what to present. So kya karne aaya tha, because hematology, as we all know, is a very niche and newest subspecialty of medicine. The beauty of hematology is it is wonderful amalgamation of clinical medicine combined with the art of laboratory sciences. And as with other medical specialties, the diagnosis can be straightforward, and at times it can be really controversial, particularly in the ICU setting. And these questions, what, where, how, when, and what to treat, is evolving, process. Most of us keep on learning from our mistakes. And as I mentioned, across the vast hematological spectrum presenting in ICU, my job is, I try to put before some cases, which are our real life cases, which we manage together at Yashoda Hospitals. And this is going to be just a nutshell, brief summary of managing such critical situations presenting in critical care units. So, when we think of hematology and critical care, the association is quite bilateral, and it can be both ways. The hematological issues in patients presenting in ICU, like cytopenias, hyperviscosity, and as sir mentioned, the hyperinflammatory syndromes, tumor lysis syndromes, and as well as critical care patients with hematology issues like mostly cytopenias, coagulopathies, DIC, thrombotic microangiopathies, and various cytopenias. So Hematology is one such specialty, as I mentioned earlier, a wonderful amalgamation. And most of the times when we come across such difficult diagnosis, which necessitates teamwork, most of the hematological emergencies have an algorithmic approach, and I intend to present before you cases and thereby simplifying these algorithms, which can make your practice of managing patients with these hematological issues simple and easy. Again, these are the emergency cytopenias. Mostly the most dreadful cytopenia is febrile neutropenia, when the neutrophil count is less than 500 in a patient with fevers, leukocytosis leading to leukostasis and tumor lysis syndrome and DIC. But of all these different types of hematological emergencies, I am going to highlight, because I think 45 minutes is a very quality time to focus on select common critical hematological issues in ICU. So I'm going to highlight on three important issues: the hyperinflammatory conditions like HLH, cytopenias with emphasis on the commonest cytopenia in ICU is thrombocytopenia, and also one of the differentials of thrombocytopenia is thrombotic microangiopathy, a medical emergency. So probably the other hematological emergencies we can discuss on the part two of this continuation of this talk. So the 5 real life case scenarios with key elements on history examination, how to recognize the crucial signs and symptoms, how to optimize the investigations to understand the underlying basic hematological process, which can simplify the management. And the punchline is, you can always call hematologist to tide over such critical, life-threatening clinical scenarios. So with that, I'll start with my first case. This is a 29-year young lady presents to our ICU with hypotension, hypoxia associated with history of fever, and she was found to be pancytopenic right from her CBCs done outside. When she was admitted at our ICU as a diagnostic thorough workup, we did the CT chest and abdomen, and CT abdomen particularly showed hepatosplenomegaly with marked splenomegaly and multiple micro abscesses in the spleen, as you can see on this CT scan. And as I mentioned, the labs done at our ICU showed CBC showed profound pancytopenia, and this patient also had DIC in the form of raised PT, APTT with low fibrinogen. And going on further, she was started on appropriate antibiotics, aggressive supportive care, inotropes for hypotension, supplemental oxygen for hypoxia, and subsequently the blood cultures grew Streptococcus pneumonia and Staphylococcus aureus, which were kind of pan antibiotic sensitive. So antibiotics were directed as per the sensitivity pattern. However, after 72 hours of initiation of these targeted antibiotics, even though the blood cultures were negative, but she continued to have persistent fever with more progressive, profound pancytopenia. And because she was kind of severe sepsis with septic shock with DIC, she was continued on cryoprecipitates as well as FFE transfusions to maintain her fibrinogen above 1.5 grams per deciliter. And because she was having diffuse oral, nasal, mucosal bleed as well as continuous hematuria, she was continued to be transfused with platelets. Despite the resolution of the underlying sepsis, she continued to have persistent pancytopenia. And moreover, after 4th day of her stay in ICU, this young lady started to deteriorate with worsening dyspnea, hypoxia, and tachycardia. So she was actually she developed type 2 respiratory failure requiring intubation and mechanical ventilation, and antibiotics were further escalated. And this was the time point because of her resolving sepsis but persistent pancytopenia, hematology consult was sought. And looking at this lady, this patient is sick, pancytopenics with significant splenomegaly. The question was, does she have something which all of us are familiar with, which, brings tremors to in our day-to-day practice, something called as hemophagocytic lymphohistiocytosis, HLH. So HLH is a severe life-threatening hyperinflammatory syndrome. Basically, it is because of overactivation of macrophages, natural killer cells, and cytotoxic T lymphocytes, resulting in a cytokine storm, which will eventually lead to multi-organ dysfunction, as seen in our case. So the associated conditions underlying such HLH can be, the commonest one are autoimmune disorders, viral infections, hematological malignancies like lymphomas and leukemias. Another setting in which it is seen commonly in patients who are on post-solid organ transplant like kidney or liver transplant, or patients post-hematopoietic stem cell transplant. And of course, there is a subset with genetic predisposition who have recurrent such hyperinflammatory syndrome, HLH. So if you look at the pathophysiology, as I mentioned you earlier, whatever the trigger, autoimmune disorders, infections, transplants, malignancies, or genetically predisposed primary HLH, there is a excessive activation of these CD8 positive T lymphocytes, which is ineffective because even this excessive CTL, cytotoxic T lymphocyte activation, is not able to contain the trigger, and that will lead to hypersecretion of cytokines like interferon gamma, GM-CSF, which will lead to overactivation of macrophages. And this macrophage, NK cell, and cytotoxic T lymphocyte activation will eventually lead to hyperinflammation, and this will eventually set a vicious cycle in which the cytokines secreted by these macrophages again reciprocally continues to activate more and more cytotoxic T lymphocytes, and that cascade goes on. So how do you know if this thing is going on in any sick patient, cytopenic patient in ICU? So nowadays everybody carries the smartphone, do the H score, and the life has much simplified with all these kind of algorithms. We didn't really need to scratch our heads to come up with this not so uncommon diagnosis, particularly in the setting of ICU. So again, the clinical presentation revolves around three classical findings: refractory fever, vanishing blood count, and hyperinflammatory markers. The most notable of them is ferritin. Again, mind you, even in such hyperinflammatory conditions, if you just continue investigating CRP as a marker of infection, most of the times our HLH diagnosis can be missed, and these patients can have a high mortality. So is it definitely HLH? Again, the answer is to the H score, or rather than going through the say 7 characteristics, 5 out of 7, presence or absence, just do the H score. And most importantly, ferritin more than 3000. Under such appropriate clinical scenarios, the HLH suspicion should be kept in mind. And more so, if ferritin is more than 10,000, it is 95% sensitive and 90% specific for the underlying possible HLH. So again, the treatment of HLH in such severely cytopenic, sick, moribund patients in ICU is intensifying immunosuppression like HLH 94 2004 protocol, steroids, etoposide, cyclosporine, that is intensifying immunosuppression. Of course, the newer agents like empalumab, which is a macrophage inhibitor, or the other targeted agents like cytokine inhibitors like IL-1 receptor antagonist anakinra, or the IL-6 antagonist tocilizumab, or the JAK inhibitor ruxolitinib can be newer rescue life-saving medications under these dire critical situations. Again, For those of us on this virtual platform, I would like to remind you, HLH is a double-edged sword in ICU. Your overdiagnosis can kill the patient, and your underdiagnosis also can kill the patient. So it has to be thorough clinical as well as lab evaluation. It can be a bless or curse. And as I can show you here, this is a 2022 paper. You can see the patients with HLH started on HLH-directed therapy. Depending upon the time of initiation of immunosuppression, you can see the mortality can be between 80 to 90%. Those who fail to respond, so the survival can be 30% who fail to respond, whose ferritin failed to go below 1,000, whereas those with less than 1,000 ferritin with prompt initiation of HLH-directed therapy, you can see the outcomes can be rewarding 80 to 90%. So again, as I mentioned you earlier, under such dire pancytopenic, sick, febrile, moribund, toxic, sick patient in the ICU, intensifying immunosuppression with steroids, etoposide can be a real challenge. Of course, the newer agents, ruxolitinib, anakinra, and the most important, we should aggressively investigate to search for the underlying cause, because hematological malignancies, autoimmune disorders, unless and until you trace the underlying cause, or genetic HLH under appropriate clinical circumstances, these patients will continue to deteriorate with very high mortality. Now, coming back to our case, he was started with steroids, etoposide, IVIG, but she continued to be febrile with pancytopenic with persistent clinical deterioration, and ferritin was shooting beyond 10,000. So at this point of time, because soluble IL-25, the turnaround time for us to, we outsource, and the turnaround time is 5 to 7 days. So we have our in-house protocol. We do peripheral blood immunophenotype for the cytotoxic T lymphocytes, which was consistent with HLH immunophenotype confirming the diagnosis of HLH. So at this point of time, as a rescue medication, we started her on ruxolitinib, and within 5 days of ruxolitinib, her counts recovered. She no longer required transfusions. Within 7 days, she became afebrile, and all lab parameters, including ferritin, started rapidly dropping down. And within 10 days, she was absolutely recovered from this devastating HLH. Extensive investigation was done to rule out the underlying, the secondary triggers for HLH, like autoimmune disorders, malignancies, and the genetic HLH panel report was awaited, which was done in view of her young age, 29 years. And at 10 days, she was being planned for discharge. So again, tips for HLH, I will say all ICU patients who are sick, febrile, pancytopenic, or cytopenic should get ferritin on admission. Hyperferritinemia audits across the globe has shown that up to 50% patients can have a missed diagnosis. Ferritin done just for the investigation of anemia more than 10,000, as I mentioned you earlier, can be 95% sensitive and 90% specific for the diagnosis of HLH. Do the H score, very easy, just few seconds on the smartphone on these smart algorithms. Early recognition is a key. Key flags, again, immunosuppressed inflammatory diseases, refractory fever, vanishing counts, inflammatory markers. I'll stop just for a minute here, and I would like to share the thoughts of our critical care specialist, our moderator, Dr. Venkat Raman, sir. So what do you think? Doing ferritin for all sick cytopenic patients in ICU setting, is it appropriate to not miss such HLH diagnosis, sir?
Sir, in clinical context, definitely yes, sir. Not all, but yes, when you have a clinical context where you are thinking about a hyperinflammatory phenomenon, I'll give you examples. We had a recent season with dengue,
Yes,
and
sir.
we have seen after a week time, patients were transferred to us with a fever ongoing, and you saw the cytopenia taking more time. Generally, we see the leukopenia, thrombocytopenia after a period of a week time in critical phase, it generally takes off. But when your cytopenia persists, your fever persists, and that is the time where in all the dengue patients where we thought in critical phase having fever, we try to consider this. Second, in enteric fevers, where we saw instead of a leukocytosis, leukopenia, even though it is not uncommon, persisted in on treatment, on maybe ceftriaxone, on maybe azithromycin, and persisting fever, which is not uncommon in also enteric fevers. So as you said, the triad of ongoing fever on appropriate treatment in a clinical context with a cytopenia needs to be evaluated for markers. And yes, ferritin can be a non-specific marker, can be elevated in a wide spectrum of clinical contexts. As you said, it can be double-edged, it can overdiagnose. But yes, we need to think about and involve a hematologist that will guide us. See, I have seen Dr. Ganesh and his team visiting our ICU many occasions where the ferritin was high, but we all sit together. I remember in maybe more than 50% of times, we just said we look for a trend. Tomorrow we will review back. If the ferritin is in a dropping down trend, the fever is settling down, you're treating the primary disorder, we hardly done anything. Some of the situations where the ferritin was more than 6,000, 25,000, 30,000, secondary HLH, maybe a small dose of steroids did help in many of them. And in primary HLH situations, we use this etoposide where that probably we hand over the case to hematologist who take the calls. And very rare situations, I think this complex treatments were required in situation. So what I strongly believe, we as a critical care clinician who deal day in and out the referred tertiary care cases from peripheral centers in second week with ongoing fever, with a cytopenia, this should be in our mind. Otherwise, we lose the crucial times.
Yes, sir. Thank you so much. So because there are many ICU units across the globe, more so in the Europe and North America, where just like we keep doing CRP at admission, they have started doing a baseline ferritin and under the appropriate clinical circumstances, a repeat ferritin in such cases. So I think it is worthwhile to do a baseline ferritin for such sick cytopenic patients to not miss such life-threatening situations. So again, HLH demystified. Thank you, sir, for that, valuable suggestions. As sir mentioned, ferritin more than 3,000, keep a high index of suspicion for HLH, and ferritin more than 10,000. Definitely, you have to consider HLH and try to, depending upon the clinical circumstances, you have to take a call. Again, top causes, mostly the infections like CMV, EBV, tuberculosis, again, so full list of triggers, lymphoma, PET-CT, flow cytometry, autoimmunity, a rheumatological screen, and the bad genes when, young patients like this or patients who have recurrent hospitalizations with cytopenia and sepsis. So again, initial therapy, dexamethasone and anakinra can be life-saving. Of course, anakinra is not available in India, but exit strategies just like the case we treated, treating the underlying trigger as Kola sir mentioned, but the novel rescue agents like JAK inhibitor, and we have many patients who had a recurrent refractory HLH, which were rescued with timely hematopoietic stem cell transplant. Now, changing gears further, the second, of cytopenias, thrombocytopenia is a common occurrence, particularly in ICU. So, most common hematological consult across ICU settings, more common in surgical trauma patients than with the medical patients. And again, one of the commonest hematological issues in ICU, and across the studies, it has been found that it is associated with high morbidity as well as high mortality. To just mention you the statistics, mortality can be 4 to 6 times higher if thrombocytopenia is persistent beyond 4 days, and it can also be a marker of serious medical illness independent of bleeding events. So when we think of thrombocytopenia, these kind of algorithms, the underlying etiologies can be very easy to simplify evaluation. So thrombocytopenia can be basically due to two major underlying mechanisms: increased destruction or decreased production from the marrow. Increased destruction can be immune or non-immune. Immune is either ITP or various autoimmune conditions, as well as thrombotic microangiopathies like TTP. Non-immune commonest is DIC. Decreased production can be either primary hematological issue like hematological malignancies, aplastic anemia drugs, or due to ineffective production due to the nutritional deficiencies like B12 folate, or infections are the rare congenital defects, particularly in the pediatric population. And the third commonest cause is sequestration from splenomegaly of various causes. The commonest one is splenomegaly of chronic liver disease, infections, autoimmune conditions, hematological malignancies, and the most notorious are sequestration or destruction because of the consumptive coagulopathies like DIC and APML, which are the medical emergencies. Now, in particularly in ICU setting, we have to focus on more serious life-threatening conditions, which are like HIT, heparin-induced thrombocytopenia, immune or drug-induced thrombocytopenia, DIC, thrombotic microangiopathies like TTP, HUS, sepsis, and many a times in ICU setting, particularly the ICU thrombocytopenia can be multifactorial. Again, these are the common etiologies. So thrombocytopenias can be not just associated with bleeding, but can be associated with thrombosis. And those associated with thrombosis carries the more grave prognosis and are kind of hematological emergencies. The time to diagnose and intervene is crucial for successful salvage of these patients. So these are like the microangiopathic hemolytic anemias like TTP-HUS, and the second commonest is heparin-induced thrombocytopenia. Third is DIC, and fourth is catastrophic APLA. Whereas those associated with bleeding mostly either infections, drug-associated thrombocytopenias, and rarely immune-mediated thrombocytopenias. So with that, I'll start another case. This is a 42-year young neurosurgeon from Kadapa. He was admitted at Yashoda long back with swine flu. He with completely wiped out lung with ARDS, and he was on ECMO. He has developed progressive thrombocytopenia with a nadir platelet count of 30,000. And that was why the hematologist was called in. On examination, we found superficial skin necrosis over right thigh. And if you look at his hemogram, barring modest thrombocytopenia with platelet of 30,000, hemoglobin mild anemia 9.9, WBC fine, WBC differential fine. And on the biochemical evaluation, the LFT and RFTs were normal. Coagulation parameters with PTA, PTT was unremarkable, but LDH was high, 1455. So again, in the clinical context, I'm sure most of you might be shouting in your mind about the possible diagnosis, heparin-induced thrombocytopenia. We all know the pathogenesis is platelet activation because of the trigger, like mostly surgeries. With this heparin, there is platelet activation, which leads to activation of coagulation cascade, leading to conversion of prothrombin to thrombin, and this thrombogenic systemic thrombotic microangiopathies leads to more consumptive coagulopathy, leading to thrombocytopenia, which is modest. And the clinical presentation, the temporal aspect, the 4Ts, classical 4Ts of thrombocytopenia, the time of onset. So usually between first 5 to 8 days of heparin exposure. Of course, there are delayed onset or rapid onset hit. Those who have previous heparin exposure can be seen, and this is the typical, nadir thrombocytopenia, and this is the 4T pre-test probability of hit. Again, can be calculated readily on your smartphones. So depending upon the score, you can devise basically thrombocytopenia, timing of platelet fall, thrombosis, or any other sequelae, other possible causes of thrombocytopenia. This is the algorithm. So score more than 4, usually the heparin PF4 antibody or SRA test, but most of the times the pre-test probability, we go ahead with it and we change the anticoagulation. The treatment is stopping the heparin and using non-heparin anticoagulants like lepurudin, argatropan, danaparide, fondaparinux, or bivaldurin. Again, depending upon the organ functions, you can choose the anticoagulation. This anticoagulation has to be continued for at least 2 to 3 months if there is no thrombotic events, and if there is a thrombotic event, like in our case, at least 3 to 6 months. Again, these are the heparin preparations used clinically and those associated with HIT. So again, nowadays the direct thrombin inhibitors are available, which can be used as a rescue anticoagulants for patients with HIT. So again, this kind of, there are case reports of newer DOACs and NOACs, dabigatran, rivaroxaban, and apixaban for HIT. and this can also effectively salvage the patients with HEAT. And if you miss the diagnosis of HEAT, the patients can have very high morbidity as well as mortality because of widespread consumptive coagulopathy and systemic microthrombi. So another and alternative anticoagulant is fondaparinux. So again, going by the same sequence, another lady, 49 years, history of SLE, hypertension, stroke, admitted with cellulitis and possible UTI, started on IV antibiotics as well as heparin for DVT prophylaxis because of her comorbidities and long-standing bedridden status. On the fifth hospital day, as with the timeline of HEAT, she developed thrombocytopenia with a platelet count of 60,000, 66,000. And now, how will you approach this case? Of course, HEAT will be a common clinical probability based on your pre-test 40 score. So appropriately, in this case also, heparin was discontinued. The antibody score, which was reported negative. However, the platelet continued to decline to severe thrombocytopenia to up to 18,000, and she was symptomatic in terms of mucocutaneous bleed and extensive bruises. Now, how will you approach this case? So this was, of course, the case of UTI leading to sepsis, and this was sepsis associated probably DIC, PTA, PTT was subsequently done, which was raised, and again, she was managed with aggressive antibiotics and FFP transfusion support. So again, some other, this thrombocytopenia is, I'm just trying to highlight the clinical context and the appropriate lab evaluation directed to the clinical context. The differentials can vary, as I mentioned, HEAT, DIC, and again, this is a SPOT polytrauma patient. Again, hematologist was called in for thrombocytopenia, and this was the first picture we saw right in the ER, emergency department of Yashoda Hospital, Hitec City. So I'm sure you might have again clues about the possible diagnosis. So another clue is subnormal temperature. So polytrauma patient, you can see extensive ecchymosis on the chest, thoracotomy tubes, and extensive oozing, and the oozing is so rampant that the underlying bedsheet is completely soaked with blood. So this is definitely a case of polytrauma with DIC, and the cause of thrombocytopenia is very much evident. So very important to understand when not to transfuse platelets, because transfusions can induce immune resistance as well as it can precipitate the underlying primary diagnosis like thrombotic microangiopathy like HUS, TTP, catastrophic APLA, HIT, DIC, and severe ITP, unless severe internal bleed like CNS bleed, or you are anticipating urgent invasive procedure for which you need to transfuse these patients with platelets. Again, DIC, the overall etiopathogenesis revolves around the systemic activation of coagulation leading to extensive intravascular fibrin deposition, leading to consumptive coagulopathy, leading to depletion of platelets and coagulation factors. So this can present both ways, thrombotic as well as bleeding profile. Thrombotic, mostly 40% patients with sepsis, and overall 10 to 15% patients, whereas bleeding 5 to 20% patients. So again, no single test is sufficiently accurate to establish or reject the diagnosis of DIC. It is combination of widely available tests and clinical contests which can help to guide the diagnosis. So going on further, this is another case, 32 years primary, who was attempted LSCS for arrest of descent outside. The outside introp, the placenta was found to be adherent, which was removed manually, and subsequently this lady developed atonic uterus despite continued sequential uterotonics like oxytocin, argometrin, and carboprast. Of course, because of his profuse PPH, she was tried various surgical rescue measures like uterine compression sutures, bilateral uterine and overend vessel ligation done, and this was the time she was shifted to Yashoda Hospital. By now, she has approximately 2 liters of blood loss, which was replaced with um, IV fluids and 2 units of PRBC. She continued to have profuse bleeding PV, and this was the time she was shifted to us. Our OBGY team ended up doing subtotal hysterectomy. By now, the approximate blood loss was 3.5 liters, and this was the time hematologist was called in because the bleeding was not stopping despite hysterectomy. And looking at the clinical context, uncontrolled PPH, we added simple recombinant factor 7 at a dose of 60 mics per kg. The first dose was given, almost 70% bleeding was stopped because there was still some oozing. The second dose was repeated after 30 minutes and the transfusions were continued and the bleeding completely stopped after 10 minutes of second dose. Of course, this young lady's life was saved, but unfortunately, her uterus was gone. So had this case, had been hematologist was involved earlier, probably this is again now approved indication of these universal bypassing agents like factor 7 for such dire clinical circumstances of severe uncontrolled PPH despite uterotonic. So for us hematologists, DIC is just death is coming. And contrary to, on a lighter note, contrary to the, this was kuch kuch hota hai, and you can see Rani Mukherjee is going to die. She knows she is going to die, and she has such a time that just IV iron apparently is hanging behind, and she has such a time to draft letters for her daughter's 10 birthdays to be delivered each sequentially on each birthday. This is not the clinical circumstance which we see. The time is, the timeline is the lifeline under these dire circumstances, and multidisciplinary team approach can really safeguard the lives. Again, DIC has two bullets. The first, consumptive coagulopathy, and the first, extensive coagulation cascade activation leading to thrombotic microangiopathy, and the second one, consumptive coagulopathy. And so depending upon the clinical profile, you have to devise the treatment. So again, you all intensivists are the masters of managing DIC on a day-to-day basis. So the clinical spectrum, signs, symptoms, the diagnosis evolves around the deranged coagulation parameters with hypofibrinogenemia. Again, we have a different scoring system readily available again on the smartphones, and the diagnosis can be easy. And so depending upon the patient's clinical presentation, if asymptomatic, just LMWH prophylaxis, extensive thromboembolism without bleeding with platelet more than 50,000, LMWH prophylaxis, or overt VTE, either therapeutic low molecular weight heparin or unfractionated heparin. For overt arterial events, antiplatelet treatment along with anticoagulation. The patient has bleeding, again, prophylaxis with platelet transfusions, and the FFPs or cryoprecipitate transfusions to keep PT-APT less than 1.5 times normal, platelet above, target platelet count more than 50,000, and target fibrinogen more than 1.5 grams per deciliter. So this is depending upon the underlying cause, the approach to DIC varies. And so again, other causes of thrombocytopenia like drug-induced thrombocytopenia, the medium time to onset 7 to 14 days, time to recovery after withdrawal of the drug 7 days. So this is very important, and time to platelet nadir after rechallenge is 3 days. So this is very, very important. The commonest drugs in ICU setting is GP2B3 antagonists, and the 1% patients receiving unfractionated heparin, and rarely for other drugs. So again, the catastrophic APLA probably we'll discuss at later point of time. So another thrombocytopenic patient, this is a 39-year lady with past medical history of migraine headache. Now she presents to our emergency department with worsening headache over last 24 to 36 hours. She has no antecedent illness and no other symptoms. She's on these migraine medications, SOS. On examination, her temperature is normal, just above normal. While she's waiting in the ER, she seems to have trouble with her speech, and subsequently she has a overt seizure. So look at her lab evaluation now. Her hemoglobin is modestly low, 9.4, severe thrombocytopenia at 26,000. Again, non-oleric AKI creatinine of 1.6, and unconjugated hypobilirubinemia with bilirubin of 2.5, INR reasonably normal 1.4, and her CT brain, because of her seizures, was reported normal. So how will you approach this case? Again, she was immediately shifted to ICU. We did the workup. LDH was high, 1455. Haptoglobin was low. On peripheral smears, you can observe many these broken RBCs. Those are cystocytes. So I'm sure you again will have a diagnosis clear in your mind. This is a case of thrombotic microangiopathy, most notably TTP. How should be the patient managed acutely? How should be the patient managed subacutely? And what can be the other considerations? Again, TTP is not so uncommon, 1 in 50,000 hospitalizations, and almost 2/3 cases are seen in particularly young women. And the underlying associated conditions can be autoimmune disorders like this case, infections, pregnancy, and certain drugs. So, but remember, mortality can be as high as 80% in cases where the diagnosis is missed or delayed, or untreated patients, even in those patients when the diagnosis is prompt and therapy with plasma exchange is even prompt, still the mortality can be 10 to 20%. So the pathophysiology revolves around, normally we know that this von Willebrand multimers, they are circulating in the circulation, but the normal Adam TS13 breaks down these multimers and thereby prevent activation of platelets through these multimeric von Willebrand factor. So in the absence of Adam TS13, these multimers under appropriate triggers with endothelial activation leads to activation of platelets and subsequent activation of microthrombi on the endothelial surface, leading to extensive microthrombi in the circulation, leading to tissue ischemia, which can be evident on the peripheral smear with schistocytes, because these RBCs are squeezed through these microthrombi, and on organ biopsies, the microthrombi can't be evident. So the understanding the basic etiopathogenesis is very important to conclude the diagnosis, which can salvage many of these high mortality patients. So like the famous Telugu cinema suspense Vaikatapakil Bahubali, underlying etiopathogenesis understanding is very crucial. So the more why we ask ourselves, the more wise we become. So so again, the classical pentad of sign of TTP, as mentioned in Harrison's, like microangiopathic hemolytic anemia, thrombocytopenia, neurologic dysfunction, renal disease, and fever is hardly seen in less than 10% of the patients. But what is most important is thrombocytopenia, evidence of microangiopathic hemolytic anemia, and no alternative explanation for this phenomena. And so you have to suspect the diagnosis and start the prompt. And the most important clue is cystocytes on the peripheral smear. Your pathologist can be a vital help in diagnosing such high-risk patients. So again, patients without any cystocytes on carefully scrutinized peripheral smear, the diagnosis is unlikely TTP. So the devil lies in the details. So you have to be in touch with your pathologist under these clinical circumstances. Again, the TTP plasmic score, the platelet lysis, active cancer, stem cell organ transplant, MCV, INR, creatinine. Again, these kind of scores are, you don't need to remember all these mnemonics. Just put the values and you can get the plasmic score with the pretest probability of TTP or any such hematological emergencies in just no time. Again, very important, the differentiation of various thrombocytopenias like ITP versus TTP. Remember, in DIC, the patient is sick. TTP, the patient is sick. In TTP, the cystocytes on peripheral smear with very high LDH can clinch the diagnosis, whereas in ITP, isolated thrombocytopenia without any abnormality is the clue to the diagnosis, and the gold standard treatment is steroids or IVIG depending upon the intensity of bleeding, whereas in DIC, deranged coagulation parameters like PTA, PTT, and low fibrinogen is the clue for possible diagnosis. Again, if you see the TTP survival statistics, this is again many reputed journals, mortality more than 90% if the diagnosis is missed just by few hours. Even patients whose diagnosis, less than 12 hours, more than 12 hours, you can see the mortality can be quite, you can see the survival curves widely separated apart. So, of course, I had opened the Pandora of differentials underlying thrombocytopenia in ICU, but many such thrombocytopenia etiologies needs urgent multidisciplinary approach, urgent involvement of hematologists to salvage these patients. So again, the TTP treatments, avoid platelet transfusions is the rule unless needed for line placement in ICU. The gold standard is plasma exchange. If plasma exchange is not immediately possible, the plasma exchange should be continued till platelet and LDH normalizes. Normally, we do daily plasma exchange for first 5 days, and depending upon the platelet count and LDH, we change the plasma exchange intensity and frequency. If the plasma exchange immediately not possible, FFP 30 ml per kg, corticosteroids early in the course, rituximab in the refractory course, and also caplacizumab, unfortunately, which is not available in India, can be a savior. Again, thrombotic microangiopathy. So thrombocytopenia, microangiopathic hemolytic anemia evidence with any of the systemic symptoms like neuro, renal, gastrointestinal, then these patients need immediate plasma exchange. Again, other thrombotic microangiopathies like DIC with the deranged coagulation parameters, HUS with more prominent renal failure, oliguric mostly, and health syndrome in pregnancy, early postpartum period are the differentials. So again, switching gears further, this is another lady, 39 years. I will, Venkatramana sir, I will finish maybe another 7-8 minutes. Is that fine?
Yes, sir. Yes.
So this is again a case from Karimnagar, 39-year lady, short duration fever, 2 weeks, generalized weakness, and extensive bleeding all over from the mucosal orifices as well as extensive ecchymatic patches all over the body. See the hemogram, severe pancytopenia. Again, with the platelet count of 40,000, this bleeding profile is disproportionate. So we did a coagulation profile, PTA, PTT. You can see this bleeding is not just because of modest thrombocytopenia, but because of active DIC, PTA, PTT sky high, fibrinogen is extremely low. So this patient has thrombocytopenia with overt DIC. Again, our pathology team, we are one of the hospitals in Telangana where we have a dedicated trained qualified hematopathology services. So the hematopathologist called within an hour telling that there are no neutrophils on the peripheral smear and there are some abnormal cells called as promyelocytes 68%. So again, just like a ECG for a cardiologist, endoscopies for a gastroenterologist, and imaging like CT, MRI for neurologist, the cell counter generated hemogram, and hemogram is just not numerical values, but these histograms can be a vital clue for devising the differentials in patients with various hematological abnormalities in ICU. Coming to our patients, so disproportionate bleeding to the degree of thrombocytopenia because of overt DIC and these promyelocytes establishes the diagnosis of one of the most lethal blood cancer on earth, acute promyelocytic leukemia, M3 type of AML. Again, one of the most lethal cancers, but equally rewarding, the highest curable cancer across the globe. Cure rate can be as high as 95 to 98%. So again, medicine is a science of uncertainty and art of indefinite probability. So simple therapy, supraphysiologic doses of vitamin A and arsenic trioxide can save the lives in such patients. So take home message from this case, urgent hematology referral for patients presenting with pancytopenia or various cytopenias are patients with febrile neutropenia, patients with symptomatic severe anemia, symptomatic severe thrombocytopenia, pancytopenia with DIC, pancytopenia with abnormal peripheral blood picture, like in our case, blast or promyelocytes, or evidence of microangiopathies with cystocytes, severe pancytopenia with the possibility of aplastic anemia, pancytopenia in a persistently febrile patient with a possibility of HLH, as I mentioned in the case 1, and pancytopenia with metabolic emergencies like symptomatic hypercalcemia, hyperkalemia, and hyperuricemia with possibility of tumor lysis syndrome. So again, ICU thrombocytopenia is associated with high mortality. There are many studies like this, and compared to patients with normal platelet count, patients with varying degrees of thrombocytopenia has definitely higher mortality, and more so persistent thrombocytopenia, the mortality is high. So again, these are the various etiological groups underlying thrombocytopenia in IC. The most commonest is sepsis, DIC, drugs, liver diseases, and multifactorial. So again, the platelet transfusions under appropriate clinical requirements can save lives. So primary hematology by intensivist confirm the presence of thrombocytopenia, assess the severity and rapidity of thrombocytopenia, initial workup to include coagulation profile, evaluation for evidence of hemolysis, microangiopathy, or HEAT. Consultative hematology by hematologist for evaluation or diagnosis of underlying causes, treatment of primary hematological disorder, and reassessment when diagnosis and treatment is unsatisfactory. Again, these are the various platelet improving strategies in immune thrombocytopenias. Very important to remember. Again, I didn't mention bone marrow for all the cases. So straight to bone marrow in patients presenting with thrombocytopenia or any cytopenia when there are blasts in the blood, when there is leukoerythroblastic picture on the peripheral smear, and severe thrombocytopenia in elderly patients. So these are the clinical circumstances. I'm sure you will agree with me that thrombocytopenia evaluation and management can be rewarding, and it is not as scarier than actual reality. Switching gear further, the last part of my talk, just few minutes, hematological malignancies and thereby febrile neutropenia, mostly the blood cancers like AML, where time is crucial and the loss of time to intervene can be quite lethal. So neutropenic sepsis, particularly in ICU, 10% patients end up in ICU with severe neutropenic sepsis. Mortality can be high, particularly patients with shock, 50%. And there are various underlying disease predictors for mortality. And again, you can see causes of mortality very high in hematological disorder or malignancies patients. So again, the cultures are not always positive, only 20 to 30% culture positivity, and more so there is changing trend of more gram negative as well as gram negative, mostly the threat of drug resistant gram negative bugs, and there also gram positive can increase, particularly in patients with mucositis, with intra indwelling catheters, or patients who were on prophylactic antibiotics, and also patients on antacids. The commonest febrile neutropenia etiologies, bacteria, 70 to 90%. So within this context, I'll share a case which is very rewarding to manage with. This is a real life story. We managed about 9 years back. 9-year girl, class 4 student, symptomatic severe pancytopenia with fever, blood culture grow MDR E. coli. This was a story in December 2016. Because of severe pancytopenia, we did bone marrow and she turned out to be severe aplastic anemia. And mind you, severe aplastic anemia, neutrophil less than 50 in a patient with multi-drug resistant E. coli sepsis. So how will you manage this case? Again, this culture showing MDR E. coli. So this is the MDR prevalence in our setup, 72% in culture positive patients. So these patients can be salvaged only with timely bone marrow transplant. So she was the only child of the family. We did first emergency half mass transplant with father as a donor. Unfortunately, she rejected the first father's stem cell graft. We did second consecutive half mass transplant with mother stem cells, succeeded almost to cut the story short. More than 8 years post-transplant, this is India's first successful consecutive double half mass transplant. This girl is now 17 years, beautiful looking adolescent who has started her college recently and absolutely healthy. So these are all natu moments in hematology and critical care, but managing these neutropenic patients with neutropenic precautions is very crucial. Most importantly, what to do and what not to do. The collaborative teamwork with intensivist, hematologist, ID physicians, pulmonologist, and gastroenterologist can be really helpful. So again, we usually continue antibiotics till cultures are negative and the counts improve. So managing such cases need a different approach. So uh, again, the evolving future of hematology is all newer targeted therapies, immunotherapies, and more complex half mass transplants. So these kind of you need to be future ready. These targeted therapies, I will say surgical strike against blood cancers, immunotherapies. We are in the era of precision oncology, and these kind of patients need a collaborative teamwork. Just to highlight another case, another severe aplastic anemia with failed first half mass transplant, second half mass transplant, almost 3 years post transplant with many complications like HLH and refractory CMV. Of course, all these, the COVID has been a great teacher. This is a blessing in disguise because cytokine release syndrome and cytokine storm we learned from COVID, and I'm sure most of the hospitals are having the facility of IL-6 and all this cytokine marker monitoring. And this kind of persistent fever with pancytopenia, we should do periodic ferritin. Again, hemophagocytosis is misnomer. bone marrow evidence of hemophagocytosis is not mandatory for the diagnosis of HLH. So to cut the long story short, with ruxolitinib, with newer antivirals, this child succeeded, and not just in medical, transplant, but parallelly he continued to pursue his studies, and he was a topper in his 10th class. So like the famous saying, eyes are useless when the mind is blind. Unless and until we think of these diagnostic therapeutic possibilities, we won't end up with success. So again, hematopoietic stem cell transplant is a wonderful therapeutic modality for the cure of not just blood disorders, blood cancers, but a number of non-malignant conditions like aplastic anemia, genetic disorders, hemoglobinopathies, immunodeficiencies, and we are in the era of precision medicine. So the end result is such rewarding patients. Another half mass transplant, 9 years post transplant, nobody will believe unless and until I mention that this gentleman at one point of time was on a thin verge of life and death, and is cured and leading a normal life. So blood cancers, blood disorders are no longer a curse, and like the famous saying, every ending is really new beginning. So we'd like to take this virtual platform to share my humble, sincere gratitude for crossing 500 plus bone marrow transplants at Yashoda Group of Hospitals. So there are many things we are doing collaboratively together because of the teamwork, and just like the no more these blood disorders, blood cancers are terrible, and these unbelievable survival stories reflect the quality of critical care at Yashoda Group of Hospitals. So future of medicine, including hematology, hemato-oncology, bone marrow transplant is very rewarding, very promising, and there is a lot of light at the end of these devastating disorders. So we definitely need to change our approach to offer the best possible chance of survival success across this difficult to treat spectrum. And like the Darwin's theorem, it is high time to change our approach. And these all stories, as I mentioned earlier, I like to share. This is just a reflection of teamwork. Together, everyone achieves more. And like the famous saying, coming together is beginning, keeping together is progress, working together is success. To summarize, hematological diagnosis can be challenging. Early diagnosis can be life-saving. Delayed diagnosis can be fatal in many circumstances. Oftentimes, like HLH, you don't need to wait for the full-blown HLH spectrum to initiate therapy, because most of the times, if you wait too long, these patients have a dismal outcome. So timely treatment may need to be initiated prior to the confirmation of diagnosis. And most often, hematologist can be your savior amidst these turbulent times. And so teamwork is the key for successful outcomes. So on a lighter note, being a hematologist is easy. It's like riding a bike, except the bike is on fire and you are on fire and everything is on fire. So, but when we work together, this can be equally rewarding, as I shared through my case scenario. So with that, I conclude my talk, and I really thank, I can see 103 participants despite
Wow.
1 hour of virtual talk. So like the famous saying, education is not learning of the facts, but the training of the mind to think. I hope I had been able to share some key take-home messages for managing such hematological emergencies in ICU. And as I mentioned you earlier, teamwork is dream work. I'm really grateful to all the wonderful people I had the privilege and opportunity to work with at Yashoda Hospital, Hitec City. Thank you so much. And if our moderator permits, I'll be happy to share answers to few of your queries. Thank you so much for the opportunity again.
Yeah, you can stop sharing, sir. Thank you, Ganesh, sir, for that wonderful, extensive, elaborative presentation. You try to cover the whole spectrum of possible those four criteria. There were a few questions already, but to just before going into these questions, as you rightly pointed out, uh, the COVID has widened the understanding of the cytokine release syndrome, cytokine storm, hyperinflammatory phenomenons, anti-inflammatory medicines, IL-6, tumor necrosis factor alpha, tocilizumab use, all that spectrum which we have seen happening. So I
Yes.
just wanted to understand from you, being a hematologist and also being a part of this hematology scientific forums, we understand autoimmune disorders in one side. We have a big spectrum of autoimmune disorders. Then we
Yes.
talk about hyperinflammatory syndromes. Then we are also talking about auto-inflammatory phenomena nowadays.
Yes,
And
sir.
then we say hyperinflammatory syndromes to a cytokine storm to macrophage activation syndrome to HLH. So just can you make all of us understand in a simple form what are these all spectrum, where are how you fit all this?
So that's a very apt and a very, I must say, sir, a common clinical challenge in our day-to-day practice. So the autoimmune conditions, autoimmune disorders can be a trigger for macrophage activation syndrome, which is a spectrum of HLH, which can be managed with just milder immunosuppression like steroids plus or minus IVIG and intensifying immunosuppression underlying the directed to the underlying autoimmune disorder. But same autoimmune conditions, if they continue to progress and are not able to respond to this modest immunosuppression with persistent fever, progressive pancytopenia, ferritin shooting above 3,000, 10,000, then definitely macrophage activation syndrome bar HLH should be considered, and these patients should be added, particularly when the ferritin is more than 3,000. Macrophage activation syndrome bar HLH is a known entity. So these patients deserve more profound immunosuppression beyond steroids, IVIG, like etoposide. And if still the patients are not responding well, the already most of these patients are on CNI like cyclosporine tacrolimus, and the patients are not responding well. Just like I shared the case of a young female, the newer targeted drugs, sometimes a single shot of tocilizumab can dampen the inflammatory cascade and can be a really crucial savior amidst these turbulent times. And of course, ruxolitinib is a very fantastic molecule. Again, I will like to um, um, remind you my preposition. So HLH is a double-edged sword. Your what you call it as, sound rational based clinical diagnosis is the key to save patients, because over diagnosis is going to kill the patient because of intensified immunosuppression. At the same time, under diagnosis, and it has been found even today 2024, if we go through the literature on HLH, even in the developed nations like North America and Europe, 50% of HLH patients, particularly in the ICU setting, are post-mortem diagnosis. So that's the reason why ferritin as a simple tool along with IL-6 can plus or minus IL-6, but ferritin more than 3,000, you should have high index of suspicion. Keep the patient tracking, monitoring closely. If you are confident, again, as I mentioned you earlier, CRP procal is going to be high because these are inflammatory markers. In a such hyperinflammatory cascade syndrome, the CRP and procal will not be a deterrent to intensify your immunosuppression. So covering these patients with appropriate antibiotics, antifungals, antivirals, and then shooting your weapons with more profound immunosuppression can be a crucial
So you spoke
survival.
about a spectrum. Hyperinflammation is one side,
Yes,
cytokine releasing phenomenon, then cytokine storm, then HLH2 macrophage activation syndrome. That's a spectrum which you're talking about. The higher is HLH or macrophage activation syndrome. The initial can be a hyperinflammation. Dr.
yes, sir.
Ganesh, the most common challenge happens in the intensive care setting is any patient comes to the emergency room or ICU with a hyperinflammatory condition, high grade fever, organ failures, proven otherwise will be leveled as a sepsis with MODS.
Yes,
Cultures sent, cultures take couple of days more to come. You have high procal, as you said, high CRP, as you said, you have all the organ failures according to your definition. SOFA is in place. The newer sepsis 3 says it is a dysregulated host immune response. That also fits. So you start bombarding with antibiotic and all. So
yes,
my question is, it will be a very difficult challenge to actually differentiate a multi-organ failure leading from a hyperinflammatory syndrome or from a bacterial origin leading to that hyperinflammatory condition. So how do you think in intensive care or acute care setting, your approach will be to differentiate both of them? Proven otherwise, all of us initially put as a differential of sepsis with modes as a first diagnosis. But
Yes.
when should we consider, is this not a infective etiology, but it can be an inflammatory phenomenon?
Yes, sir. Again, a very, very important, valid, and a crucial question when we handle such patients. So, the most important here is, sir, serum ferritin. Serum ferritin more than 3000 is absolutely should raise a very high index of suspicion for possible HLH. These patients with already established organ dysfunction, if you don't add immunosuppression to dampen this uncontrolled hyperinflammatory cascade, the mortality is going to be high. And I'm sure if we do the retrospective analysis of most of our patients with the poor outcomes across the ICU settings, HLH is has emerged as one of the crucial mortality underlying mortality marker for many of these so-called sepsis with MODS, with shock. So high ferritin in constellation with low fibrinogen. So if ferritin act as an acute phase inflammatory marker, it doesn't shoot above 3000. Number one. Number two, high ferritin in a patient with sepsis with MODS, because of DIC, fibrinogen will be low, but when you replace, the fibrinogen will recover. So persistently high ferritin in constellation with low fibrinogen. Again, fibrinogen is also an acute phase reactant. So high ferritin with low fibrinogen again is a very in a patient who has pancytopenia or cytopenia with persistent fever despite all aggressive supportive care with established or impending organ dysfunction, the HLA suspicion should be high, and already these patients are on appropriate antibiotics or anti-infective measures. So there should not be a hesitation to start at least steroids in these patients. Number one. Number two, there has been a lot of reports. Of course, the best marker would have been soluble CD25. Unfortunately, it is an outsourced investigation. Not many institutes have soluble IL-25 as readily available. Turnaround time is high. But another important HLH immunophenotype on
Yes.
the peripheral blood T lymphocytes. The turnaround can be as low as 6 to 12 hours. So this peculiar HLH immunophenotyping can add to your diagnosis and can make you confident to continue to intensify your immunosuppression.
So,
So
Dr. Ganesh, one question was there on that. What is the immune suppressant marker for HLH, and what is the cost in turnaround time? Is it available in?
immunophenotype, HLH phenotype, we have established at our Yashoda group
Yes.
of hospitals. So turnaround time is 6 hours. The cost is just 8,000. But many outsourced labs, those of you who are practicing with all such immunophenotyping being outsourced, even then you can expect the results within 12 to 24 hours, and that can really boost your confidence to go ahead with more
Yeah.
intensified immunosuppression in these case scenarios. Why I'm emphasizing this is, sir, the common mindset and the thought process prevalent, as you mentioned, across all intensivists is sepsis, MODS, how can it be HLH? But that is the very reason why I mentioned doing a simple ferritin can be a vital tool. And again, IL-6 known as a diagnostic marker because we have a targeted drug, tocilizumab. When you are adequately covering your patients with all anti-infective medications, there should not be any problem, just like we did in COVID, right? Extensive use of tocilizumab for patients with extensive cytokine release syndrome. So can save many, many lives. And I'm sure in India also, if we do our own data analysis across all critical care units, many of our so-called sepsis mods, mortalities, morbidities can be due to underlying HLH, where the diagnosis either is missed or not thought of in time.
Sir, there are questions. We'll take those questions, sir. The questions are: what is the dose of dexamethasone you use, etoposide you use, and IVIG you use for HLH?
So perfect, sir. So dexamethasone dose is 10 milligram per meter square in two divided doses. So it has to be given for first 2 weeks, and depending upon the response, you can taper the dexamethasone dose. IVIG is 400 mg per kg given every 2 weeks because half life of immunoglobulins is 2 weeks. Etoposide is 100 mg per meter square, and of course, etoposide, to add etoposide, it has to be a multidisciplinary decision with preferably involvement of hematologist, because etoposide, being a chemotherapy agent, with robust diagnosis, and of all the HLH therapeutic armamentarium, etoposide is the most rapidly acting drug. Single drug, it acts on macrophages very promptly. Within 6 to 12 hours, you can see a very good resolution of cytokine storms. But it is I can put a disclaimer here, because being a chemotherapy drug, the decision has to be through a combined multidisciplinary consensus. That is one. Ruxolitinib is again a tablet form, a fantastic drug, readily available in India. The cost,
Sir?
again, little cost, 5 mg twice daily, monthly cost is around 30 to 40,000 rupees.
Duration is for a month.
Duration is at least for first initial, depending upon the response, 2 to 4 weeks, and you can slowly taper off over next 2 to 3 months, depending upon, again, HLH is not the final diagnosis in itself. You have to thoroughly investigate for possible underlying etiologies, like autoimmune workup should be complete. The occult malignancies, the commonly hematological malignancies like lymphomas, leukemias. So bone marrow with immunophenotyping and whole body PET CT scan can clinch the diagnosis of possible underlying hematological malignancies. Infections, nowadays we have all these infection comprehensive panels readily available. Particularly the notorious ones are viral infections like EBV and CMV, and more so in patients who are immunosuppressed for various underlying etiologies.
The question related to severe neutropenic sepsis. When do we do a bone marrow transplant? You probably has spoken about a patient in engraftment period having a neutropenia and managed.
Yes.
The question is related, I think, in a.
So severe neutropenic sepsis, again, the final evaluation for underlying possible etiologies, if it is drug-induced agranulocytosis, most of the times you withdraw the drug, like antithyroid drugs, anti-epileptics, anti-arrhythmic drugs, antibiotics. These are the common etiologies underlying drug-induced agranulocytosis. So withdrawal of the drug, the recovery happens over 1 to 2 weeks. So these are short-term temporary neutropenias. Again, severe neutropenic sepsis because of underlying hematological disorders like aplastic anemia or hematological malignancy, you need to work up. If it is due to hematological malignancies, depending upon the underlying hematological malignancies, you have to devise the treatment, and the bone marrow transplant is only for those high-risk hematological malignancies or very severe or severe aplastic anemia, where the neutropenia is not going to resolve and is going to be because of the underlying bone marrow defect. Whereas other infections, drugs, associated neutropenias are short-term. The careful evaluation and the therapy directed at the primary underlying primary can resolve the neutropenia in most of the cases.
Sir, in view of time, we will probably ask the last final question to you on the demand. Like, what will be the right time to give a hematology referral? Is it on the basis of some clues? What is your message to all the critical care consultants?
So I will say all ICU patients with a platelet count less than 50,000, hematology consult is a must. ICU patients with any degree of pancytopenia, patients in ICU with persistent fever, progressive cytopenias, ICU patients with various cytopenias with coagulopathy, ICU patients with cytopenias with altered mentension or organ dysfunctions. These are absolutely essential patient profiles where hematology consultation is mandatory and the collaborative team approach can be very, very rewarding.
Thank you, sir. It was an excellent overview and a wisdom expression from your side. It has been very, very clear and a message has been gone through. I think you repeatedly emphasized that a very high ferritin in the context of a multi-organ failure need to be considered in a context of an inflammatory phenomenon, add other markers, add other phenotypes when it is required with a hematology consult. And as all of us felt, it is a teamwork, multiple specialists involving your intensivist, hematologist can give a way forward. Thank you very much. Thank all the participants also to be a part of this, and we keep on trying to get more and more updated programs to all of you. Thank you, Ganesh sir. It is a
Thank you so much, sir. And it's indeed an honor and privilege to be amidst the audience. I can see it has been almost 1 hour, 20 minutes, and still there are 80 eminent clinicians on board. And I'm really, overwhelmed by such a fantastic response.
So we
And
see 100 and a couple of hundreds in the initial direct available viewers, sir. For our information, we always get around 5,000 to 6,000 viewers in every day in 24 hours time. So it is because of the high quality information you all share, and the audience probably enjoy all of your information, sir. Thank you for sharing
thank you,
those.
sir. Thank you so much for the opportunity. And take care. Goodbye, everyone. Thank you
We
so much.
conclude the session. Thank you.